Hello, everyone, and welcome to another fantastic Monday Night IBD webinar. I'm Dr. Aline Charabaty, founder of Monday Night IBD. I'm the director of the Inflammatory Bowel Disease Center at the University of Maryland Medical Center in Baltimore. And I'm joined today by my colleague and friend, Dr. Robert Battat. He's an associate professor of medicine at the University of Montreal and the director at the Center for Clinical Excellence and Translational Research in Inflammatory Bowel Disease at the Centre Hospitalier de l'Université de Montréal. Thank you for giving me a chance to practice my French. Rob, welcome.
Thank you for having me.
We are very excited today to talk about IL-23 and how we can integrate this new MOA in our practice. If you did not catch the earlier activities in our IL-23 series, you can view them by visiting the QR code, and the link is shown on your screen. All these activities are CME certified and jointly provided by PACE and Bonum CE, and they were made possible with the support of an educational grant from Lilly. Our disclosures are on the screen. And if you haven't already completed our pre-activity survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are in the polling questions below, and be sure to complete your evaluation at the end of the session to claim your free CME credits. And of course, please follow Monday Night IBD and Bonum CE and set your alert notification for more CME certified programs. So today, at the end of the session, we should all be more comfortable in using an IL-23 in our practice and able to evaluate the clinical efficacy and safety of the 3 approved IL-23p19 for patients with inflammatory bowel disease. Today, we're going to focus on IL-23p19 for the treatment of Crohn's disease and UC. We have 3 IL-23 available to us on the market: mirikizumab, risankizumab, and guselkumab. And of course, anytime we have a new MOA, there are a lot of questions that come into play, mainly about efficacy and how we position IL-23 in our toolbox. Thank you to all those who took our survey back in the fall, telling us what you want to know about IL-23, including: are they effective in bioexposed as well as bio-naive? Can we use them after ustekinumab? And how do we position them in patients who have failed or lost response to anti-TNF? And that is why Rob is here. He's going to help us answer some of these questions today.
Thanks, Aline. This is a very pertinent topic. So we are going to start with IL-23s in Crohn's disease. And the first one we're going to discuss is mirikizumab, which was tested in the VIVID 1 and 2 randomized clinical trials against 2 other arms, one of which was placebo. And this was a treat-through trial design, so this reflects the way we actually do this in clinical practice. So the patient was either tested with mirikizumab or placebo, and then they were just continued in those arms for 52 weeks. It's worth noting that in the placebo arm, if you had an initial response, they were continued. If they didn't respond, they were considered obviously non-responders and analyzed as such, and then out of compassion were given the drug unblinded, but those patients were not included in the analysis. And so one of the important points to note is that when you have a treat-through trial design, you have more time to actually see a placebo effect. And so you could have higher placebo rates because the patient has had more time to potentially show a response, as opposed to a re-randomized trial design where if you don't hit the endpoint at a specific time point, you can actually be considered you will be considered as a failure. And this also explains to why in real world studies, you always see that drug success rates are higher than you would see in a clinical trial. So looking at mirikizumab in Crohn's disease for clinical remission, so this is a symptom-based outcome in both bio-naive or those without failure and those who are bio-exposed, so those with failure on the right-hand side, you see that there are significant differences between drug and placebo in induction as well as in maintenance. And you note that there is a relatively high placebo rate, but nonetheless, you see rates of approximately 50% in both the bio-naive and the bio-failure groups at week 52. We also see that endoscopic response rates are robust and significantly more than placebo in both induction and in maintenance, with deltas of 23% reaching out to 52 weeks. And what's interesting is that if you do get into endoscopic response, a year after that, nearly 90% of patients have sustained endoscopic response. In addition to the standard symptom-based clinical remission and endoscopic outcomes, there are new patient-reported outcomes, particularly from patient groups and from physicians who see these patients all the time. We've understood that there are other symptoms that are important to patient outcomes and quality of life, including urgency as well as patient fatigue levels, which may be very closely related to disease activity. And the mirikizumab trials took a look at these, and we see that there's a separation between mirikizumab and placebo as early as 8 weeks, and somewhere between 48 weeks, you start to see a reduction in urgency more so than placebo in the mirikizumab arm. And then that actually persists throughout the entire maintenance trial, as well as in endoscopic responders. You do see that level of urgency remains low. So there's a durability to that reduction in urgency. In terms of fatigue, there are new fatigue measurement tools that have been validated in trials, and we see that using the FACIT tool, mirikizumab was effective in both induction and maintenance to reduce fatigue, and that effect was actually durable over time to 104 weeks. IL-12/23s as well as IL-23 inhibitors seem to be amongst the safest agents that are on the market. There's no black box warning, and although there have been respiratory infections and some arthralgias that have been reported amongst these agents, these are mandated to be reported and not significantly more so than seen in the general population and/or placebo.
Rob, you showed us that IL-23s are very effective in bio-naive patient and bio-exposed patient. I want to focus on patients with Crohn's disease that have been exposed to anti-TNF. What should we use next, ustekinumab or IL-23? The sequence trial really made a big media splash showing that IL-23 was superior to ustekinumab in Crohn's patient exposed to anti-TNF. Walk us through that data and the data that we have on the other two IL-23s.
Sure. So we'll start with the sequence trial, which did make big news. So this was a randomized controlled trial that was open label that compared risankizumab to ustekinumab in patients with Crohn's disease. And the finding was that risankizumab was superior for clinical remission as well as endoscopic outcomes at both week 24 and 48. The absolute efficacy rate for clinical remission at week 24 was 58% for risankizumab and 45% for endoscopic outcomes for risankizumab. And then at week 48, so later at nearly 1 year, we see that rate is about 60% for clinical remission for risankizumab and 31%. And I'm harping on the numbers because we're going to look at other drugs and we're going to see what the rates of those IL-23 agents were. It's also worth noting that ustekinumab had a very low endoscopic and clinical remission rate compared to how it did in most clinical trials. Guselkumab was also tested in a treat-through design. There were pre-specified analyses to look at patients who had had prior biologic exposure, and there is a comparison between guselkumab and ustekinumab. And what's found here is that clearly guselkumab is more effective than placebo in the induction phase for both clinical and endoscopic response at both week 12 and endoscopic response at week 48. And then the analysis comparing to ustekinumab at week 48 for having achieved both clinical remission and endoscopic response, which is a tough outcome to hit. You see that guselkumab is superior to ustekinumab at week 48 in both bio-naive and bio-experienced patients. Again, if we're looking at the endpoint rates, this is a little bit of a different endpoint than what was used for the sequence trial for risankizumab, but you see that the rates are somewhere between 40 to 50% in the bio-experienced or bio-naive patients for the guselkumab. And ustekinumab in the bio-experienced group, again, has a rate of 25%. So in the bio-experienced group, which is what was seen with risankizumab, you see that the numbers are somewhat similar, 40 to 50% for the IL-23, and then 15 to 25% for the ustekinumab. And then getting to the mirikizumab trial, so there was a ustekinumab arm. Again, this was treat through. And again, we see that clinical remission at week 52 for mirikizumab was 54%, endoscopic response was 48%, and corticosteroid-free clinical remission was 51%. And so we see that those numbers for the IL-23 agent look quite similar to what we saw amongst the other IL-23s. The difference here is that the ustekinumab arm performed much better than it did in the other trials. So you see clinical remission rate, as opposed to being in the low 20s, it's at nearly 50%, and endoscopic response is also at above 45%. So my conclusion is from all these three trials, I think that in Crohn's disease, particularly amongst bioexposed patients, we see that IL-23s as an aggregate likely have a better efficacy than ustekinumab.
Rob, IL-23 and ustekinumab, which is an IL-12/23, share some common pathway. So the question often comes up in practice, can I use IL-23 if a patient did not respond to ustekinumab?
So that's a great question, a very common scenario. So we do have some data for some IL-23 antagonists. And I think that for me, given that there's a very similar mechanism of action, I tend to, for the moment, make the assumption for all of them based on the data of some, but we will, I'm sure, be seeing more and more data for all the IL-23 antagonists. The one that has data is guselkumab, and so in patients who failed ustekinumab in the pivotal trial for guselkumab in the Galaxy trials, if they had failed ustekinumab, they were then given guselkumab 200 milligrams every 4 weeks without an induction phase. And what you see is that amongst those patients who were ustekinumab failures, there is significant efficacy amongst nearly 50% of patients. So with that, I think that if you failed ustekinumab, it does not mean that an IL-23 is not an option. And there are many patients, in fact, that I've switched from ustekinumab to IL-23, and I think that it is a viable option for a large proportion of patients.
Rob, thank you so much for reviewing this data with us. So the big question I have for you is, how do you position therapies in your patient with Crohn's disease? When do you choose an IL-23, and when do you choose a different mechanism of action?
Yeah, so my positioning is somewhat similar in both Crohn's and ulcerative colitis, with obviously some special consideration in Crohn's disease. I think for the very severe or the patients who have a reason to give, say, like a JAK inhibitor or an anti-TNF, such as fistulas, or a particular extraintestinal manifestations such as spondyloarthropathies that are axials particularly, then, those patients will get a JAK inhibitor or anti-TNF agent. But for the vast majority of patients or those who have psoriatic disease, I tend to use IL-23 as either first or second line if they've failed something else. And those are really my go-to agents for, say, over 80% of patients that I see in my clinic. So, I mean, it may sound oversimplified, but really there are particular scenarios where I need JAK inhibitor or an anti-TNF. But in most patients, IL-23s are effective, highly effective, with a good safety profile. So even in those with multiple comorbidities, that could be an option. So it's easy to use. Young women who may want to get pregnant, I feel confident that there's more and more data that is reassuring for those agents. So there's not much to think about with them. And there's only selected scenarios where I'm using TNF antagonists or JAK inhibitors at this point in Crohn's disease.
That's very, very helpful. So switching gears to ulcerative colitis, let's review together the efficacy and safety of IL-23 in UC in both bio-naive and bio-exposed.
Sure. So we'll start off with risankizumab in ulcerative colitis. So these were the INSPIRE and COMMAND trials. So INSPIRE was the induction trial where risankizumab was compared to placebo. And as in most UC trials, the responders to risankizumab were then re-randomized to get either 2 drug doses or placebo, and then followed in the open label phase of the study. And what we see is there's a significant difference between risankizumab and placebo in the induction phase in the overall group. However, in the bioexposed group, we do see that that endpoint did not achieve clinical significance. And then in the maintenance phase, so these are patients who were responders to drug and then re-randomized to either drug or placebo. We do see that overall there's a significant benefit to the drug. And in bio-naive, that effect is numerically less in the bioexposed group. That being said, amongst those who've had an endoscopic improvement, we see that that can be maintained at week 64. The pivotal trial For mirikizumab in the LUCENT-1 and LUCENT-2 trials, again, similar trial design, miri versus placebo and induction responders either get drug, one dose, so it's 200 milligrams sub-Q every 4 weeks, or placebo, and then the responders were continued into long-term extension. So what we see in the results is that clinical remission rates were higher in induction with mirikizumab compared to placebo, particularly in bio-naive, but even in bio-exposed patients, there was a delta between drug and placebo. And then as you get out into maintenance, particularly amongst bio-failure patients, you see that actually there's a 30% delta between drug and placebo, so 45% versus 15% on the right-hand side. And then what's also interesting about these data is that in patients who've had remission at the end of the trial, we see that that remission is maintained at year 2 and year 3 in a high proportion of patients. We also have data on extended induction for these patients. So, in real practice, and this is where re-randomized trials tend to not reflect real practice, there are some patients who don't meet a strict cutoff of what is a clinical response. So you have to hit a certain 25 or 30% improvement in a symptom score. But, some patients in our practice hit a 15% or a 20% improvement. And those patients often in practice will likely try to push through and see if they'll ultimately have a response. And so they extended non-responders. They gave the option to extend with open label mirikizumab IV every 4 weeks, and then they report the data at week 24. And what we see is that patients who didn't have a response at week 12 and then continue the IV induction at week 24, a third of patients had a symptomatic response, and nearly 10% of patients are in endoscopic remission. And then we also see that if you look at these patients further out and stratify them by bioexposure status, clinical response in the bio-failed population was 46%, and in the bio-naive population was 62%. And then if you extend that out all the way out to 1 year, so these are patients who pushed through and continued with this IV extended induction, we see that up to 75% of patients achieved improvement in their symptoms, and nearly a third, so looking at the total right side of the slide, achieved a complete clinical remission, which is both clinical and endoscopic outcomes.
Rob, thank you so much for highlighting this data on the efficacy of IL-23 in UC. And I'm really actually excited that you presented this data on the extended induction. It's important in our patient who have some response after induction therapy to not give up on the drug too soon because they have a high chance of responding if we keep pushing that therapy. So putting all this together, the data and your experience and expertise, how do you position the different MOAs in your care of patients with UC? When do you use IL-23 and when do you prefer other mechanism of action?
I think a big difference in ulcerative colitis is the presence of mesalamine, right? I think we don't have something like that in Crohn's disease. And so we have moderate to severe ulcerative colitis. And again, I think that in a vast majority right now, IL-23s occupy that space. I think that there are, again, hospitalized patients with acute severe UC. Anti-TNFs are the standard of care, and I think we all do that. And those patients would then be continued on. I think JAK inhibitors are emerging in that space as well, right? And then those with extraintestinal manifestations that have specific indications for anti-TNFs or JAK inhibitors. Outside of that, I think that the vast majority of patients, bio-exposed or bio-naives, will benefit from an IL-23. I think it's also worth noting that why I'm mentioning mesalamine is because we have maybe a more moderate patient, but who's failing mesalamine, and I think that's also a good space for the IL-23 agents. These are safe agents. In terms of safety, there's data that's coming out at ECHO that's now in the public space that essentially shows that a large French national cohort of 300,000 people showed that ustekinumab has the safest profile amongst all of the advanced therapies. This is obviously before the IL-23s came into the space in that country, but I think it's safe to assume that IL-23s have a similar safety profile. And so I view them as, ustekinumab with IL-23s amongst the safest agents as well. So it makes it easy to prescribe.
Thank you, Rob. This was really a good conversation. So I want to summarize key messages that I heard from you and from this presentation. One is that IL-23 are very effective and very safe drugs, and they're taking a larger part in our therapy options for both bio-naive and bio-exposed. So, going over what you shared with us with your practice, which is very similar to how I practice, unless the patient has very severe complicated disease, extraintestinal manifestation that would benefit from these specific MOAs, this is when we're using anti-TNF and UPA. Otherwise, for a patient with moderate to severe disease, with disease limited to being luminal, or patients with also psoriasis, IL-23 are really a phenomenal option, really combining high efficacy and high safety. We do have data on patients with Crohn's disease exposed to anti-TNF. The next better therapy over ustekinumab will be IL-23. We do have data, again, for Crohn's patients who have been exposed to ustekinumab. IL-23 can still be effective and an option. And finally, a good reminder that it's important to assess the patient in our practice after induction. And if there's partial response or some kind of response, it is worth it to give that drug more time to achieve complete response and remission, especially in our patients who have been exposed to more than one biologic therapy. These patients tend to maybe take a little bit longer to achieve response on a newer therapy. So I'm going to put up there a cheat sheet on IL-23 dosing. I keep that on my phone. You'll have the dosing for induction and maintenance for Miri, Gus, Riza, recognizing for Gus and Riza, there's 2 different maintenance doses for UC and Crohn's disease. They're all approved for Crohn's and UC. And so we're very excited to have them in our IBD toolbox. Thank you so much, all of you, for joining us today. Thank you, Rob, again, for sharing your expertise with us. Please make sure to claim your CME credit by completing the post-survey and evaluation form in the links below, or by scanning the QR code shown on your screen.